It's now my pleasure to introduce Associate Professor Tanya Markovic, who is a Senior Staff Specialist at the Department of Endocrinology at the Royal Prince Alfred Hospital in Sydney. She is also Clinical Associate Professor at the Charles Perkins Centre Facility of Medical and Health located at the University of Sydney. In her role as Director of the Metabolic and Obesity Services, she runs a clinic dedicated to the management of adults living with Prader-Willi syndrome. To give us an understanding of lifelong medical support in PWS, please welcome Associate Professor Tanya Markovic.
Thanks very much. So I've decided to hold this because I can't coordinate the computer and that at the same, and this and everything at the same. And remember what I meant to say. So good morning, everybody. Oh yeah, where's my thing here? So let's see if I can remember my slides. So Prader-Willi syndrome. Well, we know. Well, some of you don't know, but the problem, there are issues associated with it that are different as time progresses. In infancy, the requirements are quite different to in the neonatal period. There's severe hypotonia. There's eating problems, and suddenly, for reasons that we really don't know and that would be fascinating to work out, either the brain matures probably, and we see the manifestations of the more pronounced manifestations of Prader-Willi syndrome appear with the hyperphagia. During childhood, the main medical issues are the possibility of short stature, the sex hormone deficiencies, and the onset of hyperphagia and obesity. And then in later childhood, in adolescence, issues appear with we see more of the psychological issues, behavioural problems, as children are less difficult to control for all of us, whether they have Prader-Willi or not, and independence and demands for more independence and free living, and so then we see a lot more of the behavioural problems. So the medical issue, or the issues facing a person with Prader-Willi syndrome and their family do change over time. And I'm going to focus more on adults because I treat adults, but a lot of this applies to children as well. So I think you would all know that in Prader-Willi syndrome, the part of the gene that's affected is crucial for the development and function of the hypothalamus. And really, just about all the problems related to Prader-Willi syndrome are because of hypothalamic disease. So the hypothalamus plays a very important role in homeostasis, which is a state of balance among all the body systems needed for the body to survive and function. And we heard a beautiful talk yesterday. How many people saw Tony Holland's talk yesterday? Most of you. So he explained it better than I could. And if you imagine where all your inputs are confused and how disturbing and distressing that would be, I think it explains a lot about the behaviour of people with Prader-Willi syndrome. Now, the hypothalamus is a tiny little region in the brain that's sort of a combination of neural and endocrine tissues that is extremely important in endocrine and metabolic processes. Hormones from the hypothalamus control all our hormonal system. So, not surprisingly, in Prader-Willi syndrome, we see a lot of hormonal disturbances, which is why endocrinologists play a central role in managing people with Prader-Willi syndrome. But it's also important for really just about every other part of our survival: appetite, behaviour regulation, which is associated with the autonomic nervous system, and that relates again to Tony's work with the vagal stimulation. It's a component of the peripheral nervous system, regulating involuntary functions like heart rate, blood pressure, respiration, digestion, and of course, very importantly, sexual arousal. So sex and appetite, that kind of keeps us going. So it really does show how, it emphasises how fundamental this part of our body is. And this is just a little pictorial. It sits right in the middle of the brain. So I guess that tells you, you know, it's important function, communicating with all parts of the brain, but also right near it, don't have a pointer, I don't think. Oh yeah, here I do. Is the hypothalamus, and so signals from the, is the pituitary. Signals from the hypothalamus go down to the pituitary, and the pituitary then has a lot of signals that go to the various glands in our body, and then we get feedback from the body that feeds back to the pituitary and back to the hypothalamus. But if you don't have the original signals coming from the hypothalamus to the pituitary, then you have you have low levels of a lot of hormones. So some of the features that you'll be aware of is that because of disturbances in the hypothalamus, fever is absent or can be unusually high. So there's temperature instability through the hypothalamus, there's hyperphagia, there's an altered pain threshold. And this might be related to a very high, I don't know who I was speaking to yesterday, it might have been Tien, very high opioid levels in some people with Prader-Willi syndrome, which is quite interesting. Sleep disturbances, and you're going to hear about that, and hormonal disturbances. And I think I've covered this. So the impaired hypothalamic function really, I think, does explain most of the features of Prader-Willi syndrome. This is quite a nice slide from colleagues in Europe. I think all these will be available. I'm not going to, because I always run out of time. So, I'll talk about something I know about. So hormonal disorders in Prader-Willi. So growth hormone deficiency is extremely common. Almost all people with Prader-Willi syndrome have low IGF-1. When you actually measure it formally, it doesn't appear to be as universal, but I think you'll hear Laura talking. My understanding is that probably all patients with Prader-Willi syndrome have a degree of have growth hormone deficiency and should be on replacement treatment. I think our tests are too crude to measure the problems because it's higher up. And you'll hear about the amazing effects and how it's really changed lives for children now receiving it at a young age. Hypogonadism is also extremely common, and I think I've got more slides about this. Hypothyroidism is quite common, not as common as... So growth hormone deficiency and hypogonadism are the two most common and almost universal. Underactive thyroid in about a third or less of adults. Central adrenal insufficiency, which when I started working in this space I was very nervous about because it's a life-threatening condition. We did a great study led by Laura from Holland, where we put data together from from a number of services across the world, and in fact it is very rare in adults, 1% perhaps. Another problem that's not uncommon that I see quite a lot is hyponatremia, low sodium levels. What that's due to, we don't know exactly, but it could be related to vasopressin problems. This is another hormone made in the pituitary that controls water balance, and another name for it is antidiuretic hormone. Diuresis is passing urine, so if you've got too much of an anti-passing urine hormone, you're going to be prone to having low salt levels. And if you overdrink, which a lot of people with Prader-Willi syndrome like to drink a lot of fluid, and if you're on certain medications like, sodium valproate, that can exacerbate the problem as well. So growth hormone deficiency, what led people to think that it might be a problem in Prader-Willi? It's that people with Prader-Willi share a lot of the problems that people with growth hormone deficiency who don't have Prader-Willi have. And I've listed some of them here. Impaired intrauterine growth, short stature, small fingers and toes, low muscle tone, abnormal body composition, the low muscle mass, the higher fat mass, and as a result of the low muscle mass, low energy expenditure. We know that growth hormone treatment is life-changing, and I'm not going to, and probably, I won't focus on the children, but we believe that adults who did not, or not we believe, or there's evidence that adults who did not receive growth hormone in childhood may also benefit from it. And as I said, it's changed the natural history of Prader-Willi. So we're now treating adults who haven't had it in childhood because of potential benefits on mass, on body composition, muscle mass, bone density, mood, and perhaps cardiovascular health. We are doing provocative testing to show that there's growth hormone deficiency, and it's interesting, quite a lot of our patients have actually, I think there's only one patient who hasn't had, he's quite tall too, who didn't demonstrate having growth hormone deficiency in all the patients we've studied so far, with a glucagon stimulation test. Now, hypogonadism, it's the most common hormone deficiency in Prader-Willi, with most individuals will have it. At birth, 95% of boys have bilateral or unilateral cryptorchidism. That's where the testes are in the abdomen and have to be brought down. And most girls have hypoplasia of their labia minora. Most people with Prader-Willi will have no delayed or incomplete puberty, and they'll need hormone treatment to induce that. And it's looks like it's interestingly a combination of both central and for some dysfunction of the gonads, as well as hypothalamic pituitary dysfunction. There are a number of, so there are 5%, no more. Haven't got the exact figures there, but I'd say around, I stand to be corrected, but around 5% of people with Prader-Willi syndrome actually have normal hormonal levels, and there are women who have periods, and there are boys who have normal testosterone, but by far the majority require replacement treatment, which I consider is essential for sexual, bone and cardiac health. I think that there's some anxiety about testosterone causing exacerbating mood, but if it's at a replacement dose, a normal dose that you guys have, then it should not be. It should not exacerbate mood, and it doesn't. And I know, that there are parents who've been very worried that their child's misbehaved, and it's been at a time when they actually haven't received their testosterone. Their testosterone's been zero, there's no relationship. Premature, interestingly, despite the high prevalence of hypogonadism, premature adrenarche is quite common in Prader-Willi syndrome. This is when girls before the age of 7 and boys before the age of 9 start to develop pubic hair, and it occurs when the adrenal hormones start working earlier than expected. Adrenarche always occurs before the rest of puberty, so that you might remember when you were children. You get your pubic hairs first, but in Prader-Willi it seems to be a bit younger. It also occurs earlier in people with obesity who don't have Prader-Willi, so whether that's a factor, we don't know. Hypothyroidism in about up to 30%, and it's usually due to central hypothyroidism, so GPs often will just measure the pituitary hormone, which appears normal often, but you need to measure the actual thyroid hormone made from the thyroid gland, and I'm always reminding the GPs to use my form, not to use their own forms, to use my blood form, so the right things are measured, because thyroid hormones are very important for our basal metabolic rate. So if levels are a bit low, people with Prader-Willi don't need a lower metabolism. Protein synthesis, long bone growth, neural maturation. Central adrenal insufficiency, as I said, very rare. And we used to use hydrocortisone, if we were in doubt, more than we should have. But now the guideline is that hydrocortisone replacement should only be used if there's clinical manifestations of adrenal insufficiency and with formal testing. So it's something that I will screen for on clinical grounds. It's not the best way to do it, but if your child has had an operation and not had any untoward effects, they don't have adrenal insufficiency, because you wouldn't survive a surgery if you had significant adrenal insufficiency. It's one of these. It's an essential hormone to get through stressful situations. Now, obesity, I think you all know about that, about the risks of obesity, but this just to emphasise that this is what normal, the weight of normal children is in this sort of shaded, and this is the range, this is what we're seeing. So 50% of children with Prader-Willi syndrome are above the normal range and above the upper end of the normal range for normal developing children. Typically developing children, sorry. And this just shows again the obesity risk, which of course is much less now. This is old. How old is this? 2000 and 2008. So it's probably be quite different if we did a study now in children, well, at least in children from countries where they're able to get growth hormone. But in this particular cohort, you see that 60% of children were overweight or obese, and then by adulthood, that's gone up to 80%. The etiology of obesity, I don't think we really need to cover this in detail, but just to say that Prader-Willi syndrome is the most common genetic cause of obesity, and clearly it's related to the strong hunger. Oh, got to go. Okay, metabolic problems are related very much to the obesity, and I think the important message here, although it doesn't really show it on this slide just shows the fact that the lipid disturbances, the glucose disturbances, and the effects on blood pressure are seen in people with obesity and Prader-Willi. This is compared to obese people without Prader-Willi, and if you can reduce the weight, you can reduce all these problems substantially. And one thing that I've found very interesting is that even people with quite poorly controlled diabetes and long-standing diabetes, unlike people without Prader-Willi, who might have long-standing diabetes, it's less likely to reverse. With Prader-Willi syndrome, if you lose weight, it will go away. So the weight has a huge impact on these metabolic disturbances and is readily reversible. Cardiovascular disease, we heard a nice talk about it yesterday, but there is an increased risk of certain abnormalities. I'm not going to dwell on this. You're going to get a whole talk on sleep, so I won't do this. Psychiatric illness we've heard about, so I'm not going to cover that. Musculoskeletal disorders are quite common, as depicted here, particularly scoliosis. Why this occurs, again, I don't think we really entirely know. Is it the hypotonia, maybe? And also importantly, not shown on this slide, is osteoporosis, which really links to the growth hormone and sex hormone and possibly thyroid hormone deficiency. Gastrointestinal problems are a big issue. It's something we plan to discuss a little bit in our tirzepatide study, particularly, all these, the thick saliva affecting the teeth, the delayed gastric emptying, the reduced vomiting, risk of acute gastric dilatation and stomach rupture, and constipation, which is a huge problem for a lot of our patients. Prader-Willi, of course, is unfortunately still is we all have life-threatening situation. We're all going to go one day, but it can be, there is increased risk of death at an earlier age in people with Prader-Willi syndrome. It's much better than it used to be, but in children, sudden death can occur still from respiratory infection, hypothalamic dysregulation of temperature, the choking, cardiomyopathy, possibly central adrenal insufficiency, and in adults it occurs, it's 7% per year estimate. Well, this was again a while ago, 15 years ago, so this could be a better figure now, but this compares to 1% for the general population with things like gastrointestinal perforation and complications related to obesity, especially sleep apnea, respiratory failure, and related to that heart failure. So, oh yes, and not to forget the disease burden on families, but I'm sure that's been covered elsewhere, but I think that's very important. So the clinical management includes all these factors: diagnosing, education and support of family and carers, school givers, places where people work, and the diet and exercise is very important. Hormonal replacement is very important. The transition to adulthood is a difficult time and needs close care. And then in adult life, there are issues related to where people should be housed, safe housing, appropriate housing, and looking at behavioural and psychological problems. Now, this slide is really just to show you all the medical problems that we can see in Prader-Willi syndrome, affecting really, I have a similar slide that I use for obesity. Every bodily system can be affected, and it's mainly because of the hypothalamus. And this is a treatment algorithm. This is the sort of thing that we need to do as endocrinologists, so that it's very involved, looking at hormonal levels, bone density, sleep, cardiac function. So we need to spend time with our patients, and it's hard to do all this once a year. So we often need to see our patients more than that. I like to see my patients every 6 months if I can. And you can see the needs of someone with Prader-Willi syndrome. The type of specialists that need to be involved is very extensive. So this is just to end off. This is my last slide. This is what I consider, I sort of copied this from, I should have put her name down, from one of our Spanish colleagues. I've forgotten her name now. A lovely talk she gave us a few years ago in Milan. I've just put here the ideal multidisciplinary team for adults with Prader-Willi syndrome. First of all, yeah, they need an understanding of Prader-Willi syndrome. That's really important. And we're not going to have, that's why we need these, we need certain centres of excellence so we can educate people and so people can come and talk to us. The care, ideally, a combination of in-person and virtual. One of the good things of COVID is we now can do virtual care quite well. So I like to see my patients once a year at least, and then the rest can be virtual. In red, I've got the people that I think are essential in the team. So you've got to have an endocrinologist, of course, but not because we're so good, but because of the hormonal problems, I think, and along with this dietitian and exercise physiologist, because it's so important. Psychiatrist, I think, is very important, and behavioural specialist, occupational therapist, and a case manager who knows what they're doing. Sleep, very important. I think most patients will end up needing a gastroenterologist. Feet, podiatrist, right footwear, very important. Dentist, extremely important. And very important, the primary care physician who we should be supporting, and the PWS associations, which clearly most important. That's it. How much over time did I go? Time for a question.
Do we have any questions from the floor? Yes. Well, can you wait for a mic and please identify yourself before you ask the question?
Yeah, thanks. Hi, I'm a mother of a 10-year-old boy, Mitchell. I'm Louise Charter. Can you speak more about the hypogonadism and the link with, despite being on growth hormone, with the advanced bone age, that, like my son has premature adrenarche, but he's also presented with advanced bone age about 3 years beyond his age. Can you speak more about what investigations might be done further on the effect with how they plateau with their growth at puberty?
Yeah, I'm not an expert on this. I'm an adult. I'm not a paediatrician, but my understanding, and if there's a paediatrician here, they can correct me, is that we normally don't start sex hormone replacement till the latter part of late teenage years. So around when we're fairly sure most of the growth has occurred. So 15, 16, 17, and we start with very low doses. And that won't do any harm, you know. They don't have to have the hormone fluxes.
Thank you. Up the back here.
Phew.
Hi, I'm Lucinda. I'm a parent of a young adult with Chef-Yang syndrome, so also needing lifelong care along the lines of Prader-Willi syndrome. We're involved with the clinic in Sydney, but I'm hoping that the Centre of Excellence and other areas around the country will be starting to be involved with people with Chef-Yang syndrome as well in this lifelong care. I just
no, of course we will. Yeah. No, I see it as, you know, related. No, it's essential that we do that. Yes.
And down here, please.
Hi, sorry, excuse my ignorance around hormone testing. So I have a 6-year-old daughter who also has Chef-Yang. She was tested in the normal range of having the right hormones, but does that fluctuate over time? Like, can that decrease? Or I'm just curious about growth hormone. She's on it, but is it something you have to monitor? Can that decrease over their lifespan?
I think that I can't comment specifically about Chef-Yang because I don't know that I'm not even sure that's been looked at. But my understanding, you'll hear about growth hormone soon. I'm trying to say the right answer. Well, I don't know if there is a right answer. I would say that all people with Prader-Willi and probably Chef-Yang have growth hormone deficiency, and that they should all be treated lifelong. That the testing that we do, colleagues who know more about this than me talk about, you know, it's higher up, the deficiency, and even if we get a normal result with the sort of provocative testing, it's usually in the low normal range. And so I think growth hormone is something that ideally your child should be on long term.
Okay, thank you.
And just one more question. We have one more? Yes? Thank you.
Thank you. Yeah, Will's my name. We're parents of a child with a young man, rather, 27, with Prader-Willi. And he had severe scoliosis picked up early, and the orthopaedic surgeon said that he wouldn't qualify for growth, like it wouldn't be advantageous for him to have growth hormone. But you're saying anyone at any stage of life?
Yes, and my understanding is, again, I don't know that we know for sure, and other people can disagree, but I did bring this up at one of our international meetings because we've got a young man, not so young anymore, not your son, someone else's. I don't know if they're here, Mr. and Mrs. S, Dr. and Mrs. S, I shouldn't say that, who has quite bad scoliosis and but other problems, and I thought growth hormone might be good for him, but I was worried about the scoliosis aspect, and the consensus is that it's not a problem, that scoliosis is not a contraindication to growth hormone.
So is this a conversation we have to have with our endocrinologist?
Yes, I think your son should get growth hormone, or at least be offered it. Yes.
Thank you.
Well, thank you so much. So much vital information. Hugely appreciated.